I think we're ready now to get going with Mauricio.
Good morning, everyone. Once again, I would like to thank Aotrom North America for inviting me to share with you about extra-articular distal femur osteotomies. The learning objectives of this lecture are that at the end of this session, the learner will be able to understand the differences between a single cut and a biplanar cut for a distal femur osteotomy, recognize technical aspects regards open versus closed and wedge osteotomies, and acknowledge the variety of conditions that may be addressed by a distal femur osteotomy. Let's go back to the beginning. This is the first osteotomy that has been reported in the area of the knee. It was performed on May 27, 1835. The surgeon is John Rhea Barton. This is a procedure that was performed to address a knee ankylosis, and the patient was a physician. This physician had a knee septic arthritis when he was 9 years old, and he had a terrible flexion contracture of the knee. Dr. Barton performed this procedure, which was a closing anterior wedge to the distal femur in 5 minutes without anesthesia. And he took care not to break the posterior cortex, as you can see. So he removed the wedge, and then gradually he was bringing this leg to extension with splints and casts in order not to cause any laceration to the popliteal artery. Very ingenious at that time in the 19th century. And there is a letter of the patient to Dr. Barton saying that this has been a life-changing procedure for himself because it allowed him to go back to his practice, to life, even to ride horses. An impressive outcome for somebody that was not able to walk. The traditional teaching says that distal femur osteotomies, extra-articular distal femur osteotomies, should be advocated for the treatment of valgus knees. I'm going to show you that this is not exactly the only purpose. This is, for instance, a patient who is a 68-year-old male that came to me with right knee pain, substantial valgus deformity, previous surgical procedures to the leg, a successful left total knee arthroplasty. And when you see and you run the preoperative planning, as has been pointed out during this course, it's important to see that the knee has valgus, but it's not coming from the distal femur. The distal femur, as a matter of fact, is in Varus, and the proximal tibia is in valgus. So then you have to go where the money is. You have to address the deformity where the deformity is located. And this is why, for this patient, instead of doing a total knee replacement, because even having a tricompartmental arthritis, to do a total knee replacement in a patient with this obliquity of the joint line would be very challenging, we decided to stage the procedure, performing first a medial closing wedge tibial osteotomy, just to bring his MPTA to normal values, allowing for then proceed to a total knee replacement, a primary one, without a hinge, without any kind of wedges or metal wedges, preserving bone stock. And this is the outcome after. So if you understand where the deformity is, you're going to see that this is not a situation where you say valgus is a situation where you have to do distal femur osteotomy. Currently, there is an interesting discussion about shall we go with a single cut or a biplanar cut for a distal femur. This is how it looks like. A single cut, it's a complete cut that includes the anterior cortex, the posterior cortex, and it goes all the way to the opposite cortex, leaving a hinge. The biplanar cut, in the other way around, just cut the posterior 3/4 of the cortex and leaves the anterior cortex intact. To cut the anterior cortex, you're going to do an horizontal cut under the cortex. It's a very interesting concept, and I'm going to explain to you why this has some advantages. First, if you see what happens to the hinge, the area of the hinge that you have with the biplanar cut is smaller, but you can imagine that in this kind of situation, you have a much broader surface contact, as you can see in the drawing. And when you go with an horizontal cut, also you're under the cortex, and therefore you're not touching the quadriceps or the extensor mechanism of the knee. So in more details, what happens with the biplanar cut is that you does not harm the extensor mechanism of the knee as the anterior cortex is intact. And it allows for a more distal cut under the trochlea where you have metaphyseal bone. You can go lower. You can go to an area where the bone has great blood supply and more flexibility than the cortical bone. And this allows you to have a more stable construct. The other plus of a biplanar cut, doesn't matter if you go for open wedge or a closed wedge, is that you're going to have a broader surface area in a shorter healing time. If you see in this chart, you're going to compare lateral uniplanar, medial uniplanar versus lateral biplanar and medial biplanar. And you see how broad is the surface area when you're dealing with a biplanar cut, because you have the horizontal cut that includes the new surfaces C and D that you don't have with the uniplanar cut. With uniplanar cut, you're just going to have A and B surfaces. With a biplanar, you add C and D. Open wedge versus closed wedge. It's an interesting discussion. You can see here the lateral open wedge and in contrast, the medial closed wedge. And it's a very different concept. In my practice, when I do one or the other, I always do biplanar for the reasons I already explained to you. And in order to decide if you're going to do a lateral open or a medial closing, it's not a kind of mathematical thing. You have to pay attention to many details like leg length discrepancy, the amount of deformity that you want to correct, patient's profile, osteoporosis, and too many other things that are related to the situation. In summary, the lateral open wedge is for sure easier to perform, while the medial closing wedge is going to have a broader surface area and a faster healing. The lateral open wedge, however, has more complications related to the hardware, which is always going to cause friction to the IT band, and very often you have to come back for hardware removal. And the medial closing wedge is technically more demanding, and many surgeons are sometimes concerned about the neurovascular structures on the medial side, which I would say it's absolutely safe to go distal medial. Technical aspects. So it's a critical thing that you define the point of the hinge. And this is a very important thing to share with you. When you see the C-arm with a good AP, you have to see the shadow of the femoral condyle, and you have to see the shadow of the opposite cortex of your osteotomy, and exactly where you have the convergence of these two lines is where you'd like to have your hinge. And you see that with a medial distal closing wedge, you can go very low. And there is where you do your oblique cut, and there is where you do your horizontal cut. Also, it's a critical thing to always have a protection or a Hohmann retractor in the back. So we open the septum and we make sure that you have the Hohmann very flush to the bone. And then you go with your saw exactly following the Hohmann. Some clinical cases for you. Valgus deformity. This is a 47-year-old male, tricompartmental knee arthritis, in severe pain, in severe valgus, as you can see. He had years ago a medial closing wedge osteotomy performed to the right side, but for the left side, he came for a total knee replacement. When I talked to him, I said, "You're 47. I'll try to get your alignment back first and then see what happens. And eventually, we may consider a knee replacement later." This is how the preoperative planning looks like. You see he has a significant reduction of the MLDFA, and he has a significant valgus. In this case, these are the steps. So you try to find the ideal trajectory of your osteotomy with K-wires, and then we create a cage for the K-wires, determining the wedge exactly on the medial side and trying to converge to the ideal hinge point. Then you resect the wedge in a biplanar fashion. Then you close it. I like to have wires to secure my wedge. And then I come with a plate on the medial side. And I try to make sure that I don't have any recurvation or anti-curvation of this distal femur. The other thing is here you see how it heals together. And here you see how it compares before and after. It's a huge difference in terms of mechanical alignment, pelvic obliquity, gait quality, and this patient is now asymptomatic despite having tricompartmental arthritis. Another use for distal femoral osteotomy is Varus deformity. This is a 59-year-old female who had a history of previous infected hip replacement, osteoporosis, distal femur periprosthetic fracture. This is how she came to the hospital. You see the bone quality is not great. She has cement up to the distal femur. She has a very long stem and she's on antibiotic suppression. She had a distal femur fixation with a plate. This is how it looks like. But right after, you see she's losing alignment and she's collapsing in Varus and then progressing in Varus. And this is the time when she was sent to me for an evaluation. And then I see that she has significant Varus and shortening, pain. She has a long hip stem. She has cement that goes all the way down, short working area in the distal femur, osteoporosis. So this is the planning. We took the hardware out, everything we could take out. Then we planned an open wedge medial, not a closing wedge medial. Again, you see a biplanar cut. The horizontal cut is done with the plate, with the saw parallel to the anterior cortex. We use a special device to protect the posterior cortex. We open a wedge and we fix the medial side with the buttress plate. And then to avoid stress risers, we also protect the hinge on the opposite side and we bypass the hip stem. This is 6 weeks after. You see the pelvis is leveled. The leg length is very close. The fracture is almost completely, you cannot see the osteotomy anymore. And this patient is very functional and very happy. You see the comparison. At least, and finally, torsional deformities. This is a patient that had right knee pain, previous patelectomy, valgus knee deformity. She went to see a doctor who recommended a total knee replacement, and she accepted the idea to have a total knee replacement, and she had it. But then, right after the knee replacement, she had the dislocation of the extensor mechanism. At 30 degrees, the extensor mechanism was dislocating. Then this case was sent to me. We did the torsional evaluation with CT scans, and we could figure out that the distal femur was internally rotated by 22 degrees. And then instead of doing a complete revision in 8 weeks after surgery, we decided to go for a supracondylar derotational osteotomy. And those pins that you see above and below the osteotomy, those are the pins that are giving me guidance about the rotation. And also they help me to hold this osteotomy stable because I have an external fixator bar holding all together. To avoid displacement of the shaft. And then I do my derotation, I fix. In this case, I would say you can see a slight gap on the medial side, which I don't appreciate much. And most likely it's because the osteotomy was not completely perpendicular to the axis of the femur, which may also generate some deformity. But she ended up healing and she's completely asymptomatic. She no longer has dislocation of the extensor mechanism. It's another use of distal femoral osteotomies. Take-home messages. Distal femoral osteotomies are procedures that have a long history of almost 2 centuries. Currently, better understanding regards plane of the deformity, 3-dimension of the deformity, bone healing, stability of the constructs. We have had too many new developments, especially in the last 2 decades. Biplanar cuts have a broader surface area, less harm to the extensor mechanism of the knee. Close and wedge techniques are inherently more stable and they have a faster healing. Distal femoral osteotomies do not apply just for valgus deformities of the knee. You are able to correct deformities in the frontal, sagittal, and axial plane. Thank you very much.